Good morning, everybody, and welcome to this morning's webinar. We're really pleased to have a special guest, special speaker this morning with us, Sarah Clark. Before I dive in and pass you over to Sarah, I did just want to give a very quick introduction to our organisation, because it might be some of you in the room, it's the first time you've attended a Mindroom webinar. So just as a very quick introduction, Mindroom, we are a charity that champions all forms of diversity and supports all kinds of minds. So our mission is really to improve the quality of life for neurodivergent people by removing barriers, increasing opportunities, and shaping a more inclusive world. So before I hand over to Sarah, if there are anybody in the room who would like to know a little bit more about our services, I will pop a link into the chat. But as a means of an introduction, we have been around since 2000, where we were established by Sophie and Robin Dow. You can see Sophie imaged on the left in the white blouse, and her daughter Annie in the denim. Now, when Annie was young, she was diagnosed with a rare chromosome deletion and a form of neurodivergence. And Sophie recalls receiving this diagnosis but not having anywhere to go. So they founded Mindroom as a place to support other parents in similar situations. So today we do deliver a range of services. So we do have our direct help and support, and this is to provide advice, information around issues relating to education, rights, responsibilities, access to work, health and social care, and the service is free to children, young people, families, carers and professionals across Scotland. So if you would like to know any more information, please do get in touch with us after. And of course, we do have our link with the University of Edinburgh. And one of the things which we do throughout the year is raise awareness around neurodevelopmental condition and experiences, in particular lived experience. So this is why I'm very, very pleased to welcome Sarah today. So I'm going to stop sharing my screen to allow Sarah to do that, and I'll pass over to you. Thank you very much for joining us this morning.
So good morning, everyone. Thank you very much for signing up to this webinar this morning. And thank you, Nellie, for inviting me. My name's Sarah Clark, and my talk's on living with autism and Ehlers-Danlos Syndrome, a lived experience and research perspective. So just a brief overview of what my talk will cover. I'll tell you a bit more about my lived experience and my own diagnostic journey. I'm going to be talking about what hypermobility is and introducing Ehlers-Danlos Syndrome. I'll talk to you about my lived experience research from my MSc and my current MRes. We'll look at some brief clinical considerations for people who are autistic with EDS and look at some barriers in healthcare. I'll share a few healthcare advocacy ideas from my own lived experience. So whenever I listen to other people's talks at conferences or other people's webinars, I always find the About Me slide the most interesting of the whole talk. So what can I tell you about me? So first and foremost, I'm late diagnosed autistic myself. I was diagnosed in May 2022, and I'll tell you a bit more about that later on in my talk. I sit as a patient expert in the Psychiatric and Psychological Aspects Working Group on the EDS International Consortium. I'm an expert by experience autism trainer through the Oliver McGowan training programme, training NHS staff, and I'm also a certified trainer through the National Autism Trainer programme. I graduated last year from my Master's in Clinical and Developmental Neuropsychology, and I'm currently doing a postgraduate research degree, a Master's by Research, looking at how to reduce diagnostic delays for autistic people with Ehlers-Danlos Syndrome or Hypermobility Spectrum Disorder. I use photography, blogs and patient perspective journal articles to advocate and raise awareness of things that I'm passionate about, including how to reduce diagnostic delays. So I'm a lived experience researcher. This means that I'm researching the conditions I have myself. Now, this has both benefits and disadvantages. For example, Nellie kindly invited me to give this webinar about, I don't know, July time, but I haven't got round to it until now because I'm often in and out of hospital. In fact, I was in hospital yesterday with POT, so I might not be 100% this morning, so apologies for any slight mistakes I make. Some of my developing research interests include understanding the impact of delayed diagnosis, understanding iatrogenic harm. Now, this term means harm caused unintentionally by medical treatment, advice, or healthcare professionals. Some of my research interests also include understanding the psychosocial impact of a diagnosis, understanding the psychological harm caused by misdiagnosis, and I'll talk a bit more about my lived experience perspective from this point later on. Understanding agency and self-management post-diagnosis, and I'm really passionate about promoting equity and access to healthcare. So I'm going to tell you a bit more about my own diagnostic journey. So like many late diagnosed autistic females, I was previously misdiagnosed with borderline personality disorder, also known as emotionally unstable personality disorder. I was under a community mental health team between the years of roughly 2004 to 2019. I'd experienced severe childhood trauma, but it wasn't until 2018 that I got diagnosed with complex post-traumatic stress disorder. Now, if you don't know the difference between PTSD and complex PTSD, people with complex PTSD may experience some of the emotional flashbacks relating to the original trauma, and we don't necessarily experience visual or auditory hallucinations that people with PTSD might get. So I'd experienced about 15 years of physical symptoms, starting around age 20. So although my GP was happy to refer me to the doctors at the hospital, all the tests that the hospital doctors were requesting kept coming back normal. So the hospital doctors didn't actually believe that there was anything physically wrong with me. So it wasn't until February 2020 I'd experienced around 15 years of physical symptoms and kept being told that there was nothing wrong. So I finally got diagnosed with hypermobile Ehlers-Danlos Syndrome. So this was a relief and validation to me because I'd spent about 2 years before that saying to my hospital doctors that my cousin has EDS and I think that I might have it. But unfortunately, my local NHS hospital doesn't know much about EDS and they just kept telling me I was wrong. Being diagnosed with EDS led to being diagnosed with numerous co-occurring conditions since then, such as POTS, postural orthostatic tachycardia syndrome, MCAS, mast cell activation syndrome. I underwent surgery earlier this year for very rare abdominal vascular compression syndrome, MALS, median arcuate ligament syndrome. It was a true light bulb moment for me in the autism lectures on my MSc course. Up until that point, I didn't really know anything about autism, but one of my lecturers, Dr. Rachel Mosley, who Nellie knows, was talking about female presentation autism, and I had a true light bulb moment at that time, and suddenly lots of my life flashed before me and suddenly started to make sense. Started to think about lots of my social difficulties, my communication differences. So I went away and did lots of thinking back on my life and listened to lots of people talking on YouTube about their lived experience of autism. But it wasn't until 2 years later that I was brave enough to undergo a formal autism assessment and get diagnosed. I'm multiply neurodivergent. I'm also formally diagnosed with dyscalculia and self-identify as having ADHD and dyslexia. So in my talk, I use the word diagnosis a lot, and it's a word used lots in everyday language, but sometimes we use words and we don't actually stop to think about what they mean. So the dictionary definition of diagnosis is the discovery and naming of what is wrong with someone who is ill with something or something that's not working properly. So why does a diagnosis matter to doctors and clinicians? So it can lead to clinical treatment pathways in terms of medical management, medication, surgery. But for a doctor, it's often a fine balancing act, formulating a medical explanation for suffering through the biomedical lens versus risk of medicalisation, which can be dehumanising. So why does a diagnosis matter to a patient? I know from my own lived experience perspective, going through years of physical symptoms and my doctors not believing me and me not knowing what was wrong or having a label to be able to name the condition I had, this led to uncertainty for me, and it was really unsettling. I know that once I was diagnosed, this has led to appropriate management, treatment, and the ability to claim disability benefits. I've also found my tribe and found support from the patient community, both in terms of getting to know lots of other autistic people and learning tips and strategies to cope better with my life, and also learning lots from the EDS patient community. For me, diagnosis had led to self-management, and lots of areas of my life and my physical health have improved a lot. I've learned to make adaptations and avoid possible future disability. I've learned how to prevent injuries and because of my joint instability. Like I've already said, my EDS diagnosis has led to clues as to other correlated conditions. It's also meant avoiding iatrogenic harm from misdiagnosis. When I was under the mental health team, I spent many years on various medications which didn't really help, and now I know why. So this is an infographic from the Ehlers-Danlos Society. And to be honest, I can't even pronounce some of the types of Ehlers-Danlos syndrome. So I'll pause for a moment and let you read at the bottom of the screen. So I have the hypermobile subtype, which is the most common, and it's commonly cited that the prevalence rate is 1 in 500 people. But really, we don't know the prevalence rate because there's so many people out there who are undiagnosed. EDS is often said to be rare, but really it's rarely diagnosed. So what are the Ehlers-Danlos syndromes? They're a group of hereditary connective tissue disorders. The genes affect the structural proteins of the connective tissue and the enzymes involved in processing of these proteins. So when the 2017 EDS diagnostic criteria came out, at that stage there were 13 known types of EDS. There's since been identified another subtype, so there's now 14 known types. EDS manifestations occur on a spectrum ranging from musculoskeletal joint issues, joint laxity, jaw dysfunction, fragile and stretchy skin, neurological impacts, gastrointestinal dysfunction, pelvic floor dysfunction, mitral valve prolapse, autonomic nervous system dysfunction, orthostatic intolerance, which means you can struggle with staying upright, which is how I was feeling yesterday and why I needed to go to hospital yesterday. Fatigue, relentless chronic pain, brain fog, various infections and rashes, which are often associated with MCAS, mast cell activation syndrome. So as I've already said, I have the hypermobile subtype, which is a type my talk focuses on because that's the type I know the most about. There's no readily available genetic test for the hypermobile subtype, so diagnosis is based on signs and symptoms alone. Unfortunately, most doctors still think that being hypermobile is just having bendy joints, but it's far more than this. If you know anything about hypermobility or EDS, you've probably heard of the Beighton score before. This was initially developed for research, but most doctors use it as a diagnostic tool these days. So in order to get diagnosed with hypermobile EDS, you need to score a certain amount on the Beighton score. So this is assessed in terms of flexibility in your little fingers, your thumbs, your elbows, your knees, and your spine. For me, I have really hypermobile elbows, but some of my other joints aren't really that flexible. And I have really tight hamstrings, which is interesting. So in order to be diagnosed with hypermobile EDS, adults need to score over 5 out of 9. Children need to score more than 6 out of 9, and adults over 50 need to score more than 4 out of 9. So if you don't meet these scores, you're likely to be diagnosed with Hypermobility Spectrum Disorder, HSD, rather than hypermobile EDS. Now, this is quite a disappointment to some in the community because a lot of people feel that an EDS, a hypermobile EDS diagnosis leads to better medical care than having an HSD diagnosis. So this is an infographic from SEDS Connective from the school's toolkit, which I find really useful because I'm quite a visual person and I like diagrams and infographics. So we can see here that some of the common symptoms of EDS are severe tiredness, difficulty regulating blood pressure, persistent widespread pain, gut, bowel and bladder problems, loose joints and fragile stretchy skin. So a side note of interest is that although EDS is a genetic condition, quite a few people only seem to become symptomatic until their teenage years or early 20s. Such as after following an acute injury, a trauma or a viral illness. So for me, I had minor hypermobility issues as a child. My eyes would cross over, I had a squint, and I had a lot of difficulty holding my pen. So at school, they put those triangle things on my pen because of the joints in my finger, but no one really realised that there was a wider issue going on. So for me, it wasn't until around age 20 when I had a viral infection and I suddenly really got extremely tired and started experiencing pain. Like I said earlier, I'd experienced about 15 years of physical symptoms, so I wasn't formally diagnosed with EDS until I was 35. I'm now 41. Also, if you're born into a family with lax joints, injury, lots of health issues, people tend to think that their symptoms are normal. This is because their family members experience similar things to them. And sometimes it's not until your symptoms become really severe that you realise it could be part of a medical condition and you start to seek medical help. So on some of my slides, I've put pictures of zebras, but why the zebra? So medical students are taught to look for the more common and usual diagnosis, not the unexpected one. Medical students are taught when you hear hoofbeats, don't expect a zebra, but those with EDS and HSD are the unexpected because we have a rarer condition. So I didn't think it was necessary really to define autism in a Mindroom webinar. I did want to provide a definition of EDS, but just so that we're all on the same page here, I have put a very basic definition here. So the 2013 APA medical model definition is it's a lifelong neurodevelopmental disorder or condition, often manifesting as differences in social communication and interaction, restricted or repetitive behaviours or interests, and sensory sensitivities. The 2012 definition from Damien Milton, who I'm sure many of you have heard of through the social disability model definition, is autism is understood as a natural neurodevelopmental difference with disability arising mainly from societal barriers rather than the autistic person's neurology itself. So just as a note, as a lived experience researcher and an expert by experience autism trainer, I try to adopt neuroaffirmative language. I personally don't think of autism as a disorder or a condition, and in my MRes thesis and when I'm delivering training, I just use the term autism. So a 2022 study found that 51% of neurodivergent adults have joint hypermobility, and this is compared to 20% of the general population. So in essence, there are quite a few hypermobile people out there, but it commonly occurs with neurodivergence. So in the interest of time, I won't go through the whole slide and Nelly can send out the slides to you afterwards. but we can see from this diagram that there are many overlapping features between autism and hypermobility and hypermobile EDS. So some of the overlapping features in the middle are proprioceptive differences. Now, this is concerned with how you sense where your limbs are in space. Coordination difficulties. I often walk around bumping into things and walking into things. Autonomic nervous system dysfunction. Now, this can include POTS, which I mentioned earlier, which I have myself. MCAS, mast cell activation syndrome. Now, this in itself sometimes occurs in autism, not necessarily just in people who have EDS. Attention regulation difficulties, sleep difficulties, sensory processing differences, pain processing differences, and emotion regulation difficulties. So next I'm going to say a bit about my lived experience research at university. So I completed my MSc dissertation in 2023. I looked at what are the daily experiences of autistic people with EDS. The aims of my study were to investigate the daily life world experiences and impact of interaction of autism and EDS. I conducted online interviews with 5 female participants and analysed the data using IPA. This is a qualitative approach exploring how people make sense of their lived experiences. So we're still 2 years later writing up my MSc dissertation for publication, and it's given me a real insight of how much work goes into writing up a study and an academic paper for a journal. So we identified 2 main themes from my MSc dissertation. Theme 1 was the diagnostic odyssey and its impacts, and our sub-themes were the personal and financial costs of seeking a diagnosis, the transformative impact of self-awareness once someone had been diagnosed, self-understanding and compassion, because our participants spoke of being a lot kinder to themselves after they got their autism diagnosis, facilitating self-management, and the importance of utilising a support network. Our second theme was living with the dual autism hypermobile EDS diagnosis, and sub-themes autism facilitating self-management of chronic illness and challenges at the crossroads of autism and hypermobile EDS. So the key findings from my MSc dissertation were participants spoke of the frustrations of fluctuations of pain and fatigue being psychologically more challenging than the physical manifestations they experienced from the pain and fatigue. They spoke of what they felt were benefits of being autistic in terms of feeling of a need for structure and routine in their day-to-day life, and they found this helpful to self-manage their EDS symptoms. Very sadly, all participants felt traumatised and invalidated by their medical care. So if you've not heard of an MRes before, it's basically like a mini PhD. So I get to attend the same training as the PhD students, but it's just that my thesis is a bit shorter and the time it will take to complete my MRes is shorter than a PhD. So my current part-time MRes looks at reducing diagnostic delays for autistic individuals with EDS or HSD, and my research is being sponsored by the John and Lorna Wing Foundation. So in my MRes, I have 3 studies. Study 1 is understanding the experiences of getting an EDS diagnosis and undergoing an autism assessment. Study 2 is understanding the clinician's perspective in diagnosing EDS, and study 3 is understanding the autism assessment process, a clinician's perspective. So the aim of my MRes research is to understand more about delayed diagnosis and to help to improve health and wellbeing outcomes for autistic people with EDS or HSD. So like I said earlier, there's both fors and against of being a lived experience researcher, and it's quite difficult for me to finish work on my research at the end of the day and switch off, because my experiences align very closely to those of my research participants. So what's the possible impacts of delayed diagnosis in autistic people with EDS? Now, some of these can be around misdiagnosis and psychiatric labels, which is something I've experienced myself, like I mentioned earlier, with misdiagnosed EUPD, which is unfortunately very common. delayed access to support and treatment, increased mental health struggles, possible self-harm and suicidality, medical gaslighting and dismissal when you're not believed by your doctors, and sadly, physical health deterioration and deconditioning. Now, to share a bit more about my lived experience perspective and what difference a diagnosis has meant to me. So in 2018, before my EDS diagnosis, I'd become severely deconditioned and my pain and fatigue were really severe. So I became housebound for 6 months because I was so unwell. So then 2 years later, when I got my EDS diagnosis in 2020, I then really took a deep dive into finding out how to help myself. And by 2022, I was well enough to complete the 20-kilometre Jurassic Coast Challenge fundraising for the National Autistic Society. So in 4 years, I went from being housebound to being able to walk 20 kilometres. So hopefully that's a really powerful message about how a diagnosis can make a difference to self-management and finding appropriate treatment, helping someone get better. Of course, I'll always have problems because it's a genetic condition and a lot of my symptoms fluctuate a lot day to day. So why does this research matter? Co-occurring autism and EDS are poorly understood in clinical pathways. Diagnostic delays are common and distressing for autistic people with EDS, often leading to worse health and well-being outcomes. To our knowledge, it's the first study of its kind to explore both patient and clinician views on diagnostic assessments for this dual diagnosis. So why is EDS so often missed? Now, this is due to a lack of knowledge and awareness amongst clinicians, and sadly, a lot of doctors still have a very outdated view, and lots of doctors will say to patients there's no point in diagnosing EDS because there's no cure, but I strongly argue against that attitude. And like I've just explained, for me, diagnosis led to me finding out how to get a lot better. The healthcare system is really fragmented and patients often end up under lots of different medical specialists. So like I said earlier, although my GP was happy to refer me to hospital doctors, the hospital doctors' tests kept coming back with nothing showing. So they didn't think there was anything wrong with me. So at one point I ended up under 9 different specialist teams at my local NHS hospital, all of which thought there was nothing wrong. But really, they were doing the wrong tests and there was a failure to join up the dots in a multi-systemic condition. There's often also diagnostic shadowing and symptom overlap. Something that's come through in my research is that people become fearful of seeking medical care because they feel so invalidated that they're scared to go to the hospital or the doctor. They can become very anxious about seeking medical care, and to doctors this just appears as anxiety, but really it's a secondary reaction. Sometimes symptoms are also mislabeled as psychosomatic if the doctor doesn't really understand what's going on for the patient. So a 2024 study found that the average time to diagnosis for most EDS patients was 10 to 12 years. So I haven't included this on the slide, but a more recent study out this year found that for hypermobile EDS patients, the time to diagnosis was an shockingly average 22 years. So next, let's look at autism and EDS and some clinical considerations. So this can be in terms of sensory and the environment. I'm sure that everyone on this webinar is familiar with some of these ideas. But if we think about the typical A&E department here in the UK, typically no daylight at all, lots of beeping blood pressure machines, lots of people talking all at once. You're unsure of what's going to happen, and the nurses and doctors don't often give you a time frame of when you're going to get seen. Now, if you're feeling physically really unwell and you're in this really overstimulating sensory environment, this can be just too much for someone. Autistic people with EDS might experience differences in pain processing. It's beyond the scope of my talk, but you might have heard of something called central sensitization, and it might be something that you want to read more about. We can also experience interoceptive differences. Now, if you've not come across the term interoception before, this is to do with the ability to sense your internal bodily systems, such as being able to tell when you're hungry or you're thirsty or when you need the loo. There's also sometimes communication and symptom reporting differences, such as difficulty describing fluctuations or timelines. So something that was a common theme in the first study of my MRES was that my participants said that when they went to see their doctor, they could describe how they were feeling that day, but they just couldn't describe how they were the week before. So if by the time the doctor's appointment came around, they were feeling a lot better, they just had this inability to describe how bad their symptoms were the week before. Due to interoceptive differences, people might delay seeking help, so they might not go to the hospital until their symptoms are really, really severe and they're really, really unwell. So it's important for clinicians to ask clear probing questions and to support explanations, such as helping people describe the timelines in when their symptoms started. Now, looking back at my life, I've been through periods of severe autistic burnout, but before my autism diagnosis, I didn't have the knowledge or the language to understand what was happening or to explain to other people. And for professionals and people around me, this just looked like a mental health crisis. As I've already mentioned as well, anxiety can be misinterpreted and people can become fearful of seeking healthcare due to trauma from the medical system. But to many doctors, this just looks like anxiety in itself. So I've included this diagram in the bottom right-hand corner. So let's take a look at 5 top signs of sensory overload. So the first one, heightened irritability or agitation. So for any professionals or clinicians listening, you might have a patient or a client in front of you and they might seem agitated or irritable. They might seem like they're withdrawing or avoiding wanting to speak to you. They might seem to be having difficulty concentrating. They might be fidgeting and appear physically in discomfort. They might appear emotionally dysregulated. So it might not be that they don't want to talk to you, but it might be that they're overwhelmed from a sensory point of view. So as a clinician or a practitioner, is there anything you can do? Sometimes the smallest changes make the biggest difference. So are you in a clinical room where you can turn the light off? Is there a fan or air conditioning on? And turning that off might make the person feel a lot more comfortable to be able to engage properly with you. Now, some people might not feel comfortable to ask you to turn the light off. So it might just be you have a conversation with your patient or your client and just say, would you feel more comfortable with the light turned off? And they might not realise that that's something they need, but it could help you both. So let's now take a look at some clinical examples. So a broken bone might present differently. So bringing in an example from my lived experience perspective. So with POTS, I have lots of falls where I get very weak and very dizzy. And late last summer, I fell over and really hurt my shoulder. I went to my local A&E department with really significant shoulder pain. The A&E doctor said that there was no need to x-ray my shoulder and he just thought that it was muscular pain. But 4 months later, one of my consultants agreed to send me for an MRI scan and we found out that I had a broken bone in my shoulder. So during those 4 months, I had said to various doctors that I was in really severe pain in my shoulder, but obviously this was misinterpreted or misunderstood, or it wasn't really evident how much pain I was in. So another area that gets commonly misinterpreted by clinicians is food issues. So people end up with a misdiagnosis sometimes of an eating disorder or IBS, and sometimes this can just be around food sensitivity, such as dislikes of texture or taste or smell. It's also important for clinicians and healthcare professionals not to mislabel health anxiety. And I know for some of my doctors did give me this label because I get very interested in a topic and I go away and read a lot. And sometimes some people with autism can have a very deep focus for wanting to find out things that they're interested in. But to doctors, this just looks like health anxiety. So next, let's look at healthcare access for autistic individuals with EDS. So I've personally experienced this, but the more complex you are, the more health conditions you've got, the more intersectionalised you are, the more barriers you face in healthcare. Now, I already mentioned a lack of awareness amongst professionals and doctors about EDS. Very sadly, I've also experienced during my time under the mental health team that most mental health teams just don't know about autism or neurodivergence, and it's something that they often completely miss and overlook. Co-occurring conditions are often dismissed and overlooked as well, and this can be due to diagnostic overshadowing. Psychiatric misdiagnoses can lead to inappropriate treatments. Because of my EPD misdiagnosis, I was put on the pathway of dialectical behavioural therapy. And for me, this actually was more harmful than helpful. And although I'm a very keen yogi now and I practice mindfulness and meditation now, at that stage in my journey 20 years ago, I found that the mindfulness element of DBT was actually very harmful to me rather than helpful. Unfortunately, there's absolutely loads of systemic barriers, siloed care, like I've already mentioned, people end up under lots of different medical specialist teams and there's a failure to join up the dots for EDS and realise it's one medical condition. We always hear in the news about long waiting lists and difficulty accessing assessments. So next, let's look at some ideas for healthcare advocacy for autistic individuals with chronic illness. So if you're struggling to get an EDS diagnosis or struggling to find a doctor who will take you seriously or with the right knowledge, there's an excellent healthcare professionals directory on the Ehlers-Danlos Society website, including specialists in the UK. Really recommend taking a look at this. There's some amazing charities out there, including SEDS Connective, EDS UK, Ehlers-Danlos Support. There's also various charities for autism and neurodivergence. Might just be that logging into a webinar run by one of the charities or looking at resources on their website gives you some direction of what to talk to your clinicians about. You can Google Autism Hospital Passport, and this is just something that you can download from the internet and you can complete it and take it to the hospital with you. Or you might want to ask your local hospital to upload it to your clinical notes. So a couple of years ago, just before I did my first ever conference presentation, I was worried about how clear my speech was, because every time I open my mouth, my jaw subluxes on the right. So I asked my GP for referral to speech and language therapy for help with my jaw issues and swallowing difficulties. But I was really, really lucky that my speech and language therapist knew a lot about autism and communication differences in autistic people. She produced a one-page communication support summary, which I carry around with me everywhere these days, and it's really useful. So although I'm talking to you now, sometimes when I'm physically really, really unwell or really overstimulated or overwhelmed, I temporarily lose the ability to speak at all. So this is when the one-page communication support summary comes in really useful. There's also some amazing products out there, such as the Stickman Communications keyring cards, sunflower lanyard. So this is something that I personally find really useful as well. So when I go to hospital, I do wear my sunflower lanyard because quite often I look really well and it's not obvious that there's anything wrong with me. I also recommend understanding your sensory needs and learning how to self-regulate. So for me, I used to arrange activities back to back and not give myself any time at all in between. And this led to overwhelm and overstimulation. But for me now, I make sure I have time to take a break or a rest in between activities in my diary, and this helps me regulate and stay a lot calmer and not get so exhausted. So I've had a few patient perspective pieces published in the last few years. One in the BMJ, Help Me Trust You After My Misdiagnosis. Earlier this year, I had this piece published in the Journal of Patient Experience. And it's open access, meaning that anyone can access it without needing to pay. So the complexities of navigating the healthcare system as an autistic individual with EDS, a patient perspective. So for me, feeling well is a very careful balancing act. So my baseline functioning abilities need to be really carefully managed in terms of time management, prioritizing activities and pacing. And I need to be really careful to maintain my physical strength and fitness levels. So apologies for having to postpone this webinar, which was booked a month ago, but I had second abdominal surgery this year and I'm still recovering. So I've deconditioned a bit. So it's going to take quite a lot of work for me getting back to my fitness levels. So for me, feeling unwell is when I don't really manage all my overlapping conditions very well. For example, I'm intolerant to gluten and lactose. And maybe if I'm out at someone's house or out and I think, oh, for a change, I might just have normal milk in my tea, but this can actually lead to me feeling unwell for a whole month afterwards. So when I'm not careful about what I eat and drink and my food intolerances, I can become very unwell. As I've already mentioned, understanding your sensory needs and understanding when you're overwhelmed and overstimulated can be really important to helping you stay well. And for me, I overcommit myself and get very overwhelmed. So one of my top tips is to learn how to understand how sensory input affects your emotional and physiological feeling states. So it might be that your mood feels a bit off, or you're having difficulty regulating your attention, or your energy feels a bit low. But if you take time to check in with yourself and your day and what you've been doing, think about the clothes you're wearing. Are your clothes comfortable, or do you have I know that a lot of people find that cutting labels out of clothes makes them feel a lot more comfortable. Are there any lights in your environment that are too bright and overstimulating that you can turn off? Are there any smells? Is your environment really cluttered? And I know for me, when there's lots of stuff around me, that makes me feel really stressed out, but really just a 5-minute tidy up and putting things away can make me feel a lot calmer because there's less stuff that I can see around me. Are there any sounds? For example, I mentioned earlier how just a really low level sound like a fan in the background can be overstimulating. Have you brought some gentle movement into your day to regulate your nervous system? Now, this doesn't have to be heavy exercise. Sometimes it's just having a gentle stretch. Have you paid attention to your internal state? So have you eaten enough? Are you thirsty? Are you hungry? So my closing reflections are, with the right support, people don't just survive, they thrive. So before my autism diagnosis, I really, really struggled with my mental health in lots of different ways. I'm really grateful to Bournemouth University, where I'm studying, for all the help I've had. And if it wasn't for my masters and the autism lectures on my course, I probably would never have realised that I'm autistic. So since my autism diagnosis and the extra support I've got, I've really started to thrive in my life. So a key finding from my MSc dissertation was that being autistic can lead to many strengths, such as a depth of focus to learn and find things out and problem solve. And like I've already said, my participants said that they felt being autistic could be useful in terms of managing EDS because they felt they needed to have structure and routine in their day. So we need to make healthcare about people, not just about illness. And we need to abandon the siloed mind or body approach to healthcare, which splits up looking after the body with looking after your mental health. So these are the references that I've used in my talk and a few other useful resources. and I've put my contact details on the slide. So I have my own website here at the bottom with lots of blogs I've written, and Instagram and LinkedIn. And if you've got any questions, please feel free to email me, but I might not reply for a while because I have a PhD interview next week, which I'm very excited about, but also very stressed and need to do lots of preparation for. So thank you for listening. And I think we've got about 10 minutes if anyone does have any questions. So I'll stop sharing my screen, Nelly, and go back into Teams. I think you're still on mute, Nelly.
Well, that's a classic. Thank you so much, Sarah. Honestly, such an insightful and rather powerful webinar. I'm so grateful that you actually were able to come today, share your lived experience, your research with us today, in particular, your openness about your diagnostic journey, that intersection of autism. You've got the Ehlers-Danlos Syndrome, talked about the kind of overlapping features as well. So I really feel, and I hope that people in today's webinar will maybe have seen or heard. I know that we've got a range of individuals who come from a lived perspective, who maybe don't have a diagnosis, or they're here as a parent and carer, and their children and young people are going through that pathway, and also those who are wanting to better support maybe their colleagues. So yeah, you really highlighted the complexity, probably the importance of that timely, accurate diagnosis. I was quite shocked when you did mention it was, a couple of years ago, 10 to 12 years, but
yeah,
recent
now 22.
22 years. So that's a big amount of time. And whenever I'm doing sessions or talking to individuals about kind of supporting each other, regardless of a diagnosis, it is really doing it from a needs base, because actually if you are, for a lot of individuals, they may not have a diagnosis. So actually taking that time to listen, hear the complexity. It sounds like that diagnostic journey for you was quite, supported that self-management, your well-being, and congratulations on your achievement on your kind of run and that marathon as well. So lots and lots to take away from kind of lived experience, but your research too. So I'm really keen to kind of continue and follow your journey and follow what you put forward as well, because I know it's going to be really, really interesting.